I'm one of the genetic counsellors in our service. We're a pretty large service. It's we're both the Royal Melbourne and the Peter Mac Familial Cancer Centres a couple of years ago combined, so we're now called the Parkville Familial Cancer Centre. So I thought I'd start by talking a little bit of the bit more kind of boring stuff about familial cancer and just sort of what we do and what relevance there might be for you referring patients to us. And Erin's going to talk a little bit more about the guts of management and that sort of thing. So I think you've seen the learning objectives. So a lot of people think that genetics is fairly simple. You know, there's just mother's and father's genes passed down and mixed together, and then you get your person. But obviously these days with the Human Genome Project and all that sort of stuff that come through, it's only become more complex. We've learnt more and more about our genomes and interactions between genes and biological pathways, and there isn't that much that's simple anymore. We do, I guess the clinical genetics realm really does focus on the more simple aspects of genetics, which is single gene inheritance often. We are starting to broaden out into polygenic type effects in genetics, and you know, it won't be that long really, probably 5 or 10 years before it's really pretty mainstream. But at the moment, lots of clinical genetics does focus on that, the single genes. Just to give you a bit of an overview here, so Parkville Familial Cancer Centre, which is, as I said, Royal Melbourne and Peter Mac together. This is our fancy new building. We're actually shared between both the Victorian Comprehensive Cancer Centre and the Royal Melbourne, and it's there's still you know, hospital politics and things like that. We still have our own phone numbers and websites and all that sort of stuff, but we consider ourselves one centre. So we service the western and I guess northern half of Victoria. So we have clinics in Geelong and Warrnambool through Royal Melbourne, and at Bendigo, Mildura up through the Peter Mac part of the service. But there are other familial cancer centres, the Austin services, places like Shepparton, Wodonga and Monash out east of Victoria. There's also Victorian Clinical Genetics Services who are based at the Children's Hospital who have non-cancer services regionally. But we also have a non-cancer, I guess, for clinical genetics service, and so we're the largest clinical genetics service in Australia with all of the non-cancer stuff in there. So just to tell you a little about what familial cancer centres do, I guess our main focus is really on risk, what we would call genetic risk assessment, which is interpretation of family history information to try and provide information for families that might be relevant to their risk, and then therefore appropriate risk management strategies. We do provide obviously a lot of information, and genetics can get complex, so we talk to patients at a patient level about insurance and education, about genetics, testing, risk management, all of that sort of stuff, you know. There's a counselling aspect, of course, to what we do, and some people, you know, particularly with a strong family history of cancer, find this sort of stuff quite confronting when we give them particularly bad news, and so that's, I guess, where the genetic counsellor's forte comes into it. And other parts of our work are we call it a mutation carrier care program. So that's people where who do carry a mutation in one of the genes where they might be at high risk, and we follow them up fairly regularly. We also provide so there's a sort of a review program. We also can provide risk management for those people as well in another part of the service. So just very, very basic, just background of the I guess types of cancer, and we like to see it as the families that we focus on really at the moment in clinical genetic services are where we think that there's some hereditary basis for the cancer. So where there's perhaps a strongly acting single gene effect, or there's some particular factor which makes that family at high risk. There is another type of cancers, I guess, that we would see where there's, we call them familial, where we might think there's some sort of inherited component to the cancers in the family, and that could be based on all sorts of other different factors in the family history that that have contributed to perhaps an increase in cancer incidence in that family compared to normal. So those families, you know, there could be single genes, of course, that are responsible in those families, but due to variable penetrance in the family, you know, it might not be as expressed as much, or it could be some sort of polygenic effect. And then there's the sporadic type families where we do think it is just mostly just chance, because cancers are unfortunately a common disease. So the ones that we focus on, as I said, are the cancers where there is likely to be a strongly acting single gene. So just giving you the one which generates, I guess, a lot of our business, which is the inherited breast and ovarian cancer syndromes, and you can see here that all these different genes that we know of that are associated with inherited breast cancers are really only make up a very small proportion of the total burden of breast cancer in this instance. We do think that there are a whole bunch of, or a whole proportion of the women who develop breast cancer where there is a familial aspect to it, and some of them, as I said, could have these genes, some of them could have other familial factors or single nucleotide polymorphisms or changes just scattered around the genome which we know for whatever reason are associated with high risk. And this sort of group here is really the subject of a lot of research, and we think in the next, as I said, few years that we'll get a much better handle on that group of people and be able to provide, in fact, personalised or tailored risk management advice to people who fall into those categories. But largely at the moment, we sort of focus on this group here. So a lot of different inherited types of cancer. So I've talked about, you know, hereditary breast and ovarian cancer, largely BRCA1 and 2, but there are some other genes as well, and Erin will tell you a bit more about those. Lynch syndrome, which is an inherited, used to be called hereditary non-polyposis colorectal cancer, which was a bit of a mouthful, but they renamed it because they started to realise that bowel cancer isn't just a factor in it. There are other cancers that are associated, and in fact, in some of the genes that are involved, some of these genes here, cancers like endometrial cancer are actually more prevalent than bowel cancer. Familial adenomatous polyposis, which in its classical form is a really pretty nasty disease. It's people get hundreds of polyps develop in their bowels quite often at early ages, and have to have their bowels removed at sometime around teens and early 20s sometimes. There are a whole lot of other rarer diseases which we deal with, I guess it feels like to us quite a lot, but comparatively they're not really much, and I think Erin will talk a little bit more about those as well. So I thought I'd just focus on the first bit of when someone is referred into us, and I'll tell you about who to refer and that sort of thing later. But as I said, a large proportion of our business is really about risk assessment, and so we use the family history as one of our major tools to provide that risk assessment at the moment. And so we're quite comprehensive in gathering family history information, and I guess if a patient is referred into us, we kind of feel obliged to go the whole hog and get as much information as possible so that we can give them the most accurate assessment. So we look at a couple of things in that in the risk assessment. So the person's risk of developing cancer types, and most of this presentation I'm focusing on breast and ovarian cancer, and the probability of having inherited a mutation. And of course, those can be different. So you can be at high risk of developing cancer, but the chance of harbouring a BRCA mutation, for example, is low. And there are a whole lot of different factors that can play into that, some of which I'll talk about shortly. So I think it's one thing that we find often challenging to explain to patients is that they could be considered at high risk, but their chance of having a BRCA mutation might be, in the order of less than 1% kind of thing, and we have some algorithms that we use to do that. So that's because we use our assessment based on the family history and other information. So I wanted to just refresh your memories about Angelina Jolie, and many of you who were practicing around that time probably had an influx of patients. This has changed genetic services all around the world forever. When she came out to say that she carried a BRCA mutation and had prophylactic mastectomies, and then later on she had her BSO, we had just insane amounts of people referred into us who were generally the worried well, but with families' histories, and we had to turn off our phones, and we had to close down emails, and it was just pretty ridiculous, actually. We felt pretty substandard services. This is all around the world, but since then we've actually really, and it took years to kind of implement this, but we've had to change our practices. We used to accept all comers, basically anyone who was referred in to us for assessment. They're obviously concerned about something. Let's get to the bottom of it. We'll take their family history. We'll try and work out what their risks are. But these days, because of pressures like this, we have a complex triaging process, and this is really the simplified version of it. But I think the main thing to point out is that that when referrals are received by us, they're triaged by a genetic counsellor, but we also sometimes take them to multidisciplinary meetings, depending if there's some complexities in the referral. But the point here is that when referrals look like they are probably only low or moderately increased risk as a sort of overall assessment of the likelihood of that person developing cancer, we unfortunately do have to discharge them, and so we provide letters back to the patient, but also back to the referring doctor, explaining sort of why, but also a little bit about how to manage that patient. And I guess our brief from the Department of Health is really to focus on the high risk people. We do try to when someone's assessed as high risk, the first step usually for the bulk of our patients is sending out a family history questionnaire, and we do rely on patients to get those back to us. And some patients, the burden of collecting family history is actually too hard, and unfortunately that lots of the time self-selects them out, and it's obviously difficult for people with other language backgrounds and things like that. We do make efforts to, if we think that there are other conflicting factors, to contact them in other ways, but the bulk of our patients just go through this process here. And we of course do get these days, based on a treatment or management changes that can be associated with BRCA carriage or carriage of a gene. We often find ourselves seeing patients where there's some sort of treatment-focused decision, and there are other cases as well that are individualised. So there's quite a bit that happens before the appointment, and that's where I thought I'd give you a bit of an example of the kind of families that we see. So once we get a family history questionnaire back, we turn it into a pedigree like this. We have a program to do this, and look at the family history. And we look at this lady here. So I'm just thinking that the referral might have been for this person with the black arrow here, Carla. She's referred in. She's concerned. She's got a sister who's just been diagnosed with breast cancer. Sorry, these are a little bit tricky to see. And a mother who's had breast cancer, and there are a smattering of other cancers in the family as well. So we would look at that family and go, oh, okay, that she looks, there's a bit of cancer there, but breast cancer at 46 and at 60 probably wouldn't actually fit right into the high risk sort of assessment criteria for Carla. We'd probably consider her more in the order of moderately increased risk. So we use some computer program algorithms to determine the likelihood of carriage of a BRCA mutation. And so if we were to put this family history into one of these programs, one of them is called Boadicea, and there are some far simpler ones as well, and Erin will tell you about one of those, which is quite a good one. But this one here says that there's if we were to test Annette, and obviously ideally we wouldn't test Carla because she's unaffected, and even if there was a BRCA mutation in the family, she may not have inherited that. So if we were going to test someone, we'd obviously want to test an affected person first, because they're more likely to be carrying a mutation. So if we were to offer testing someone would offer it to Annette, she'd only have a 3 or 4% chance of carrying a mutation based on this family history. So that's something I just wanted to show to you. But what we do is we have a very excellent relationship with the Cancer Council of Victoria, and all of our family trees are sent to the Cancer Council, and the Victorian Family Cancer Register it's just an incredible resource. They look up every single patient on the pedigree, and obviously the full details of the patient, including dates of birth and things, and they match the records. And we have here in Victoria, back to around 1984, there's compulsory reporting of any cancer diagnosed in Victoria. So all of the records are here for Victorian families, and sometimes they, for the major hospitals, go back to the 70s and 60s as well. So we can get really good information, even if it was back 20 years ago, for these families. And so we use that information to make our assessment as well, and obviously we're checking up, Carla's been referred into us, but we're checking up information on her sister, her mum, uncles, so we can't feed any of that information back to her, but we can use it in our assessment. That's the sort of privacy agreement. So in terms of genetic testing, we use these things like this computer program called the Boadicea score, and there are a whole lot of different other factors that we assess, and again focusing on breast and ovarian cancer, we look for features such as high-grade tumours, in particular ER-negative tumours, but if all the hormone receptors are negative, this is called a triple negative tumour, and there are some other pathological factors as well that we use that really make it quite indicative of a BRCA mutation being present. Epithelial ovarian cancer in itself, without any family history, there's enough of a chance of finding mutation that we're happy to generally accept all of those referrals. And there are all sorts of other factors here as well, including ancestry. So we put all that information together. We get the information from the Cancer Council as well. And what I'll show you here is that once we've got this information back from the CCV, we've verified that not only we've got the information on this pathology here, but we've also got this Auntie Kate here who died in 1998, age 54, who Carla had reported she had some sort of cancer. She actually had ovarian cancer. And that really changes the assessment. It actually makes us think, okay, well maybe this is a bit of an outlier cancer, if you like, in Carla's mum, and this is the side of the family that's important for genetic assessment. So we've now got first degree relatives, one with ovarian, one with breast cancer. So go, okay, well let's think about Melanie then. If we were to test her, there's actually, in light of knowing this information, there's actually an 18% chance of finding a mutation. We can go even further than that, and if we actually incorporate Annette's breast cancer information, so we've identified through the Cancer Council that we've actually got a triple negative breast cancer in Annette, So once we have that pathology, you can see how much the chance of a mutation changes. So we've now got 61% chance of identifying a mutation in a NET. So obviously if we identify a mutation, it's useful potentially for a NETs treatment, but in terms of Carla and the rest of her family, this opens up the door for predictive genetic testing, which is obviously a much simpler process. It's all, it's all funded. We look for the specific mutation that's been identified in a NET, and for Carla, it's going to be, well, I guess we'd, assume that it's come through the paternal line. We would obviously offer predictive genetic testing to any of the family to explain that. But if Frank here is a carrier of the mutation, then there's a 50% chance of each of these children being affected as well, or carrying a mutation as well. So they would all be offered predictive genetic testing. So just a little bit about the practicalities of genetic testing, just done by a simple blood sample. And as I said, we would normally test either the youngest affected or the person in whom we most think is most likely carrying a mutation. And that's a complex discussion sometimes, because in this example here, we might be talking to Carla, can you actually ask your sister, if she's interested in doing this, or ask your cousin, and sometimes those conversations are difficult as well. So we talk to the patients to give them tools. We can't contact a NET directly, but we can certainly give Carla some tools, and we can give you some information to pass on to a NET. So the initial type of testing, which we call mutation detection, is a pretty high detection rate if there is a mutation present. And these days it's performed usually using a targeted gene panel. So we used to do just single gene testing, but with the technology these days we can perform a whole lot of tests. Some people ask, well, if you can test all these genes, why just not test everyone for everything? And the reason, or there are a few reasons for not doing that, I guess. One is that we're increasingly coming across what we call variants of uncertain significance, VUS, which is a change or a mutation in one of the genes, but we're not really sure what that mutation does. So does that cause cancers? Is that responsible for the cancers in the family, or is it just part of our normal genetic variation? So obviously the more genes you test, and particularly if they're less common genes, the more of these VUS you're going to get. And often it doesn't actually help the cause. So we try to focus it in on the genes that are going to be of relevance. So this is really difficult to see, but this is, we do most of our testing through the lab at Peter Mac, and there are whole bunches of different panels here. The most common one that we do for breast and ovarian cancer is this called BRCA+, which includes the BRCA1 and 2 genes, plus a few others, which Erin will mention a bit more, which are a bit rarer genes, but can be associated with breast cancer. And obviously, depending on the family history, we might look at, as a sort of a multidisciplinary team with the clinical geneticists, we'll make decisions on perhaps testing some of these other panels as well. So usually it takes about 6 to 8 weeks to do the testing. It's partly because it's batched, but also the interpretation is what takes a lot of sort of man hours, I guess. It can be done in an expedited basis in about 2 weeks, but at the Peter Mac lab they use a different platform to do the testing if it's done on an expedited basis. So they actually only do the BRCA1 and 2 tests. So often the family history suggests that it would be silly not to do these genes, so we only do this expedited test if we think it's really going to make a lot of difference for the person's management, for example. So the genetic counselling aspect of it, I guess, is associated with, we see these patients first for their initial appointment and again for results. And we go through, I guess we want to make sure that they're very informed about what they're doing and the pros and cons of genetic testing. And we talk about, I guess, how would it be for you if your mutation's found, etc. And we also think about family communication. So if there's a mutation found, we're going to need to tell family about this, how's that going to work, and that sort of stuff. So I'm running out of time, so I won't say too much about this, but in the genetic counselling sessions, we talk a lot about the implications for a person's own health as well as for other family members, and things like guilt come into it a lot when you're talking about genetic carriage, where parents, for example, might be concerned about passing a gene on to their children. Issues such as life insurance and employment discrimination. We also talk about things potentially like pre-implantation genetic diagnosis, whereby the IVF processes can be used to exclude passing on a gene to the next generation. Often with adults onset genetic conditions, we generally don't test minors, but in certain circumstances we do, and particularly if there's any medical indication for it. In terms of the funding aspect of it, so genetic services, and I guess part of the reason that genetic testing is still expensive, it was a lot more expensive and a lot more time consuming. It's become a lot cheaper, but it's still an expensive process, and I guess genetic services are given a bucket of money from the Department of Health to facilitate this, and we have to kind of limit that resource and make it equitable for all the patients, and that's part of the reason that this sort of quite complicated genetic assessment process has come into play, because we want to make sure that everyone's getting the same deal essentially for the money, and that's why we can't just test everyone as well. So with the BRCA testing, as you will know, a couple of years ago the MBS started funding that testing. When it came out in the press, it was just, hey, genetic testing for all, but it's not quite the case. The person does have to be affected, and they have to be assessed as greater than or at least 10% chance of finding a mutation based on the some sort of assessment criteria. And at our service, as I said, internally we use that complicated program called Boadicea, but there are some simpler versions, and Erin will talk about iPrevent. There's also another thing called a Manchester score, which is a simple way as well. So people can self-fund testing, and the cost of the BRCA Plus testing, which is the standard one that we do for breast and ovarian cancer, is $450. We've often found, I guess, we've had families who have gone through this assessment process. After we've got the family history and everything, we've fed back to them, look, actually, this is good news. You're only at moderate risk. You're not in the really high risk category. You probably don't need genetic testing. It's not going to be that useful for you. People still want to do it, and so despite being, I guess, targeted as a high risk service, we're increasingly finding families where we are sort of assessed as lower risk but interested to self-fund. So at our service we've instigated a thing called a seminar. I guess it's a group discussion where one of the oncologists will go through what it means to carry a gene, the chances of carrying a gene, and generally give some examples about risk assessment, and it will often resonate. Lots of the families or the people that go to the seminar and are interested in self-funding are people who have had they're often women in their perhaps late 20s, early 30s who have had a mum who has died at a young age from breast cancer. And sometimes those cases still are only at low or moderate risk in terms of the risk assessment, but they're keen to self-fund testing. So once they've come to our seminar, they can self-fund their testing at that time if they want to. There are lots of private companies who do it. There's a smattering of services around Melbourne, and I guess I didn't want to pick out anyone to individualise. I thought I was a bit more okay to just talk about two enormous, US-based services called Invitae or Color Genomics, who offer a sort of a send-in DNA type test, but they're, we would see them a lot more kind of validated as a test rather than something like 23andMe, for example. These companies provided really quite comprehensive reports and test proper gene panels, and we're pretty confident about the type of testing they do. So, but those can be facilitated privately as well. I've put some resources there. This one here you might find really useful, EVQ, and it has referral guidelines, also all the standard risk management guidelines. This one is quite useful just for contact details of genetic services. So that has all around Australia, including sort of where to go for regional services. I think you've got slides with these, and so that's why this slide here obviously can't read any of that, but I put it up specifically, I guess, so that you've at least got it down somewhere. This is our referral guidelines. So it talks about both hereditary breast and ovarian cancer and some of the factors that we look at, and also gastrointestinal, bowel cancers, polyposis cancers and other rare ones, and Erin will say a bit more about those. So as I said, we still unfortunately have 2 different phone numbers and email addresses and things, but we have genetic counsellors, about 20 genetic counsellors at Parkville, and we're happy to take calls if you just want to have a quickly just call us up to see whether a patient's worth referring or not. Other than that, I'm going to finish up and hand over to Erin.